Good evening, everyone. This is Terry Monteva. I am here with Dr. Barbara Pober for Ask the Expert. This, I want to let you all know, is on aging and Williams syndrome, and it is the largest webinar we have ever held in terms of attendance. So clearly, you don't need to hear from me. You need to hear from Dr. Pober. And if we, just to give you a little bit of a synopsis, I'm not going to read this whole bio, but you all can. But anyway, as you all know, Dr. Pober is a geneticist and a pediatrician and has been seeing patients with Williams syndrome for over 25 years and sees hundreds every year, and is just a wealth of information and a huge friend of the WSA and all of us. And so without further ado, Dr. Pober, the screen, the microphone is yours.
All right. Well, thank you, Terry. Thank you, everybody, for tuning in. Actually, I'm going to ask you to go back to the very first slide for just a minute. One more. Yes. So this is part 2. We held, I don't want to say the same, but the part 1 of this webinar back in August. There were so many questions that were submitted, we did not make it all the way through. So as I will show shortly, I'm going to give a little bit of an overview and some of the particular highlights from part 1 in case there are those joining in this evening who were doing other things on August 19th. But then we'll definitely get into some new questions that were not covered in the first go round. So the next slide. The important thing to notice is that I'm a geneticist. So many of these questions are cardiology or orthopedics, and you will see that my depth of knowledge in some of these other areas is not as considerable, but I will let you know what I know and what I don't know. That will become very obvious. Next slide. And so there, I'm going to respond to questions that were submitted and, as I say, share some answers, some insights, but also let you know what I don't know. And it seems like there's an opportunity for you to submit questions that Terry can share with me, time permitting. Next slide. Okay. Also important to point out that since I don't know your child or your family member with Williams syndrome and all the workup and medical details, my comments cannot be viewed as prescriptions or specific recommendations, but really more as ideas for you to consider. And then next slide, please.
Yep. Hang on, something. Something has just, there we go.
Okay, so back in August, I had organized the questions that came into 4 big areas, and we only made it through 1 and 2. Next slide, please. So part 2, which is today, back 1, please. I'm going to give a little bit of a high-level overview and some of what I think are the key takeaways of some of the previous questions, but it's my understanding that the webinar from August 19th is recorded, and you can listen to that at your leisure. And each of the questions I provided more detailed answers for than I'm going to be giving today. But we'll still follow the same outline. Next slide, please. So these are excerpts from 4 questions that underlines kind of the key issues. In A, this parent writes that she or he have a daughter nearly 55, want to know more about anxiety and depression. Before I get further, I want to point out again, I'm not a psychiatrist, and I know future webinars are going to discuss mental health issues by mental health experts. So again, my takeaway is going to be fairly general on anxiety and depression, but but I want to be able to share some of my perspective from having done this. Terry, it's not 25 years, it's 33 years of
We're not
providing. So the 55-year-old adult was depressed and under psychiatric care. And as written here, she shot herself. The parent went on to write that she has survived, but there's still ongoing concerns about depression and what appropriate therapies are. The next question that I've excerpted in B is a parent writing about increasing anxiety. And this is a young man who left his job of 10 years due to stress he could no longer handle. And then the parent writes some more about some of the medications that the psychiatrist has now prescribed. But the parent goes on to write, I'm very hesitant to give my son these pills to manage himself, and adds he's definitely a hypochondriac. The question that I've excerpted and put in item C here describes a 48-year-old man who lives in an apartment with another special needs adult. There's limited monitoring. A home coordinator does come in to help out, but at his job, hours continue to get cut back. And this young man, although he's kept busy enough, when you're left alone or during downtime, he can get into some unhealthy situations and behaviors. And lastly was a different question asking about strategies to manage short temper and anger management issues. So again, I don't have the therapeutic answers for all of these, but I'm going to provide an overview and a few takeaway messages from my perspective. So the next slide, please. So responses to the first three vignettes or descriptions that the parent shared. What I've written here goes without saying. Anxieties and phobias are common. Major depression is less common than is anxiety. So major depression has a very specific set of diagnostic criteria, and that is different than what gets called dysthymia, which is general sort of sadness or sort of feeling down and blue. You know, why is my sibling going off and getting married, or they have a car and I don't? That is different than major depression. And although major depression occurs and can trigger suicidal ideation, it is not. It is in more in the 10 to 20% kind of frequency, as opposed to anxiety, depending on how broadly you define it and who is defining it. Anxiety probably meets diagnostic criteria in at least half of individuals with Williams syndrome. So the treatments, which I'm not going to go in great detail, particularly medication, the specifics of medication, I'm going to let the mental health experts elaborate on. But from my perspective, medication and the right medication can be helpful, very helpful, but that's in a subset. For most of the individuals that I follow, medication plays a role, but it's generally a small piece or a smaller piece of the pie in terms of treatment. The other items that I've listed here can be more important. Again, depending on the underlying diagnosis, and medication can be the major treatment, but it often is a small part of the treatment, and optimizing these other areas that I've listed here are key to improved mental health. And daily structure, the importance of whether it's having a job, a day program, community activities, but the importance of getting out with daily structure, contributing to your community, interacting with individuals can't be understated. There is too much free time is not the friend of an adult with Williams syndrome. Living situation, and there are a variety of living situations. Some are better for adults with Williams syndrome than others, but optimizing the living situation can also improve mental health. And then therapy, not so much the kind of therapy that you or I might go to for anxiety or depression, but more working on skills and strategy to help the adult with Williams syndrome recognize if they're becoming anxious, working on skills to sort of de-escalate, but while they're feeling well, so they can call upon them when they are anxious. A few specific items that I want to highlight from the questions that the parents wrote in. Two of them pointed to less work. I mean, in one, the hours keep cutting back, and in the other, the adult just can no longer continue with their job. I observed inability to continue working in a significant subset. So there are adults with Williams syndrome who seem to be chugging along. Everything seemed to be going fairly well, both with residential situation and their vocational situation. And then for unknown reasons, by and large, the adult with Williams syndrome can no longer do their job. Whether it's an internal change, and we'll elaborate on that in a minute, or whether it's an external change, a new boss, a new colleague, whether the demands of the job have changed, that all needs to get investigated. But there are certainly more than a handful of adults that I follow who have decided that they can no longer do the job that they actually had been doing fairly well. And again, it's important to try and explore why, but in none of the situations that I've seen has the individual been able to go back to their job once they've said, I just can't do it anymore. The other observation that I want to share has to do with self-administration of medications. And I think it was the B question that was written in. The parent was reluctant to allow their adult with Williams syndrome to self-medicate. And I think having caution about that is appropriate. Many adults are responsible and administer their own medications fairly faithfully, but there have been more than a handful of situations where the adults, and again, for not entirely clear reasons, stopped taking their medication, whether they overheard about some side effect. But they said, I'm just not taking this anymore. We've had the other direction. Well, one pill's helping a little, maybe two pills will help more. So I think we want to support and provide as much independence as possible, but given the fact that inappropriate dosage, particularly for certain classes of medication, can have medical consequences, I think building in some way of monitoring that medication is being taken properly on a regular basis, I think that's important. And that overall, both for sort of physical well-being, mental health, the last bullet point I just want to share on this slide is my view is that most adults with Williams syndrome need an increasing level of support for activities of daily living as they get older. So the activities of daily living, the personal hygiene, room cleaning, laundry, etc. These, as a general rule, these are not a strong suit for most adults with Williams syndrome to begin with. But as folks get older, my sense or what I hear, what I'm told, is that in fact they need even more support to engage in these ADLs to at least some level of proficiency. And that's actually kind of a hard message, because they want to be as independent as possible. And yes, they can brush their teeth, but doing it consistently and doing it well generally requires a degree of support, and as I said, more support over time. So on the next slide, the last question that was written in had to do with anger management, and here I just want to raise the possibility, or want parents or family members to think about what do outbursts mean. So everybody can have a bad day here and there, and we don't make too much of it, but consistent or recurrent outbursts, again, it raises the questions I posited on the first slide. Is there some change in the environment, or is there some change with the individual? In terms of could there be a change with the individual, the two possibilities that I outlined here are, is there a mental health change? So has anxiety worsened? Is there depression? Is there some other mental health problem that has appeared? So recurrent outbursts, I would suggest that you at least consider a mental health evaluation, preferably with a psychiatrist knowledgeable about Williams syndrome. I appreciate depending where you live, that's easier said than done. And then the other aspect to consider is a neuropsychological evaluation. That's a fancy word for detailed IQ test. And there are really two reasons I think for getting neuropsych testing in this kind of setting, again, with outbursts or somebody saying, I hate my job, I don't want to go anymore. The two reasons are, is someone having a loss of intellectual capability, or what we might call dementia. Fortunately, this is uncommon in Williams syndrome, whereas dementia is quite common in adults with Down syndrome. Dementia is quite uncommon in adults with Williams syndrome. Doesn't mean it can't happen. It could happen for family genetic background reasons unrelated to Williams syndrome, but making sure there hasn't been a loss of skills can be important in teasing apart, again, this setting. Why are there outbursts? The other reason to obtain neuropsychological testing is for a better definition of strengths and weaknesses. Often because adults with Williams syndrome have relatively good language skills and relatively good people skills, there can be inappropriate expectations for a job, for a day program, and the neuropsychological testing can document strengths and weaknesses, and then it's easier to make sure that what's going on, again, in the job or at the residence or at the day program, that the expectations are in line with the individual's abilities. So over here on the right, just some new things to share since particularly the August update. I'm on the research advisory board, so I'm aware of the fact that the WSA has received a proposal to fund a study that would examine anxiety and a possible treatment for anxiety. I mean, this is incredibly exciting. I mean, there has been no systematic evaluation of any class of medication for the treatment of anxiety in Williams syndrome. So that the fact that this could be coming down the pike is very encouraging. The other item that I want to bring to your attention is more to raise awareness in you. It's a group of disorders that goes by several different names, variously called pseudo-seizures, functional neurologic disorder, conversion disorder, and it also goes by the name of PNES, psychogenic non-epileptic seizures. So these are episodes where there's a change in the individual's responsiveness, that is alertness, a change in movement, so that could be shaking or twitching or limpness, or behaviors that look like seizures and are incredibly scary, but after a thorough neurologic workup are shown not to be seizures by several criteria, including the fact that the EEG, the brainwave test, is normal during these episodic changes. So although there can be emotional triggers for this group of disorders, the research is increasingly indicating that these have a neurobiological basis, aberrant connections between the parts of your brain that control emotions and that control, let's say, motor movements. Why I raise this or want you to be aware of it is that although the onset of seizures in adults with Williams syndrome can occur, it's not unheard of, but it's quite rare. So that the onset of what looks like seizures should at least get the appropriate providers, and that would be psychiatry and neurology experts, should get the appropriate providers to at least consider this group of disorders. And I wouldn't be the right person to diagnose it. These specialists would be, but just to plant the seed that as part of a seizure workup, consider the possibility that these disorders are occurring, particularly if the seizure workup is negative. So if we could move to the next slide, I'm going to then review some of the big picture issues, and then also, I think, start on some questions that we didn't get to last time. So next slide, please. So these were some very big questions that I'm not sure if I spent an hour on this slide I could answer. So again, a high-level overview. Some of these were already discussed, but can I discuss life expectancy, common health or cognitive issues as individuals age? Are there preventative health, diet, exercise, treatment options we should employ now? What about tests your doctor ought to be doing as part of annual health care? What can we do to prepare for support services, in-home care, assisted living? And then it was a sentence in one of these questions that I've pulled out. Have any Williams adults developed essential tremor, as our daughter had? So again, very high level overview. Next slide, please, Terry. Okay, so the life expectancy question is absolutely the question we get every time we meet a newly diagnosed individual with Williams syndrome and their family. And frustratingly, there is no life expectancy study. It's a challenging study to undertake, but it is not an impossible study to do. So it's disappointing that there are no data on this. I can tell you that we follow lots and lots of adults with Williams syndrome. I mean, the oldest woman that we knew lived to 91. We follow lots of 50, 60, 70-year-olds in our clinic. But in terms of what we call an actuarial table, life expectancy statistics, unfortunately, no data exists. In terms of common adult medical problems, I'm going to show you a table on the next slide. I think you got a glimpse of it. It's a very scary table. It's really not intended to be a scary table, but it is a scary table. The important thing to appreciate is that no one with Williams syndrome develops all the potential problems on this table. This is a table, it gets called anticipatory guidance. It kind of alerts you and medical providers of things that could happen, but nobody with Williams syndrome develops all these problems. So that's the good news. We're not going to dwell on this table. We're just going to highlight a few things. Before I get to that, in terms of the essential tremor question, it's very common. There are actually two kinds of tremors that we see in adults, what we call a resting tremor, so that's a very small tremor, and then what gets called an intention or action tremor. That's the one that if you're trying to pick up a cup of tea or have soup on a spoon, there's a fairly large amplitude tremor. These should get evaluated by a neurologist to make sure nothing else is going on, but in the vast majority of cases, it is part of Williams syndrome. It does not represent an additional neurologic problem like Parkinson's. Medications, many of the adults have tried medications, but I can say that almost all of them have stopped them because the medications really didn't do anything to help at all. So on the next slide, this very long, scary table, these are alphabetical. The point to point out, there's some things that there's really very little we can do about. If we look at the dental system, if we see a higher frequency than in the general population of abnormally shaped teeth, there's really very little we can do about that other than bonding, let us say. But poor dental hygiene is something that we can provide more support for with more frequent dental cleanings, weekly adult assistance, or as one of my wonderful families said, adult touch-up after the adult has done their own brushing. But poor dental hygiene, I mean, because we want to prevent dental decay and gum disease. There are other things that are probably a combination of genetics and environment. So IGT, impaired glucose tolerance, that's pre-diabetes and diabetes. It's a very strong genetic predisposition. One of the genes in Williams syndrome that's missing must be contributing to this. But the extent of the problem can be modified. We can minimize the problem by greater physical activity and minimizing weight gain. That weight gain and lipedema, the pear-shaped distribution of weight gain that occurs in some people with Williams syndrome. In our work, we think there's partly a genetic predisposition in Williams syndrome to these findings, but again, they can be modified or minimized through environmental or so-called lifestyle changes. So I am happy, and my email is at the beginning of this presentation. I'm happy to take individual questions by email and chat with you and help you decide on next steps. Because, as I say, we certainly cannot go over each of these problems in the few minutes that the slide is displaying. Sorry, next slide. So the preventatives, I mean, they're the same preventatives that we should be putting in place for our own physical and mental health, but even more so here. I mean, we see better sugar numbers in even our heavier adults with Williams syndrome who continue to be physically active. But can we avoid or prevent obesity, encourage healthy food choices, and avoiding bad sleep habits? I mean, one of the vicious cycles that I see is adults with Williams syndrome often are fatigued. We do see easy fatiguing for unclear reasons. They come home, they take a nap, they're then up late, snacking in the evening, and then have poor sleep at night, and then it's a vicious cycle. Daily structure, so as I already mentioned, yes. Yes, Terry?
Oh, sorry, I thought I lost you there.
Okay. Am I still here?
Now you're back.
Okay. Daily structure, avoiding social isolation. I mean, to me, I spend a lot of time thinking about these preventatives because I don't think they're a minor part of the solution. I think they're a major part of the solution for maintaining and optimizing physical and mental health. The part where I'm challenged is how to get the adult with Williams syndrome to embrace this as opposed to feeling like it's a punishment. And, you know, this is something that I think a lot about and would like to continue to think about with you, with families, how to get this to be the norm as opposed to we're going to make you exercise now that you've gained some weight. So if this can be sort of part of the lifestyle, I think that would go a long way to optimizing health. In terms of maintaining sort of cognitive abilities, I am a firm believer that if you don't use it, you lose it. I knew a lot more French in high school when I was studying French, and I don't use it, so I've lost it. I think this applies to everybody. I think it applies particularly to adults with Williams syndrome who've worked so hard in school, and then once they leave school, their brains aren't stretched anymore. So I think we need to think of ways to continue to challenge and engage adults with Williams syndrome intellectually to again optimize mental health and cognitive health. Now, in terms of monitoring guidelines, they exist. We published some 15 years ago, and then there was a dated 2001 Healthcare Supervision for Children with Williams syndrome, but a brand new one, if you give me the next slide, Terry, was just published in February 2020. So Healthcare Supervision for Children with Williams syndrome. This was led by Colleen Morris, consulting with about 10 other Williams experts. So two things to say about this. These were put together in 2016 or 2017, so they're already several years old. But because it was published by the American Academy of Pediatrics, I believe there were 50 committees that had to sign off on it, and that took 3 years. So some of these recommendations are already dated and probably don't have sufficient scientific underpinnings, and so it's already the right time to reevaluate this. Even though this is published in a journal called Pediatrics, if you can do the next slide, but it should just be a screenshot that's going to come in, Terry. So yep. Here are the anticipatory guidance. This is not all of it. You can see that because it's the journal Pediatrics, the greatest detail is in under 18, but adult recommendations have been added as well. So this is a vast improvement over the ones that were published in 2001, but it's a stepping stone. There is a continued need for new and better healthcare monitoring guidelines, especially for adults with Williams syndrome. Next slide, please. Okay, zooming on to medical concerns. So here, the areas that I know and that I don't know will be very obvious. Next slide, please. So here's a question: what percentage of children with severe constipation adapt as they grow older and attain relatively normal bowel function? And then I think I organized this with another GI question, which is on the next slide. So this is a 25-year-old who's been experiencing stomach pains for 2 years. GP says it's constipation and irritable bowel syndrome. Mom wants to know, I assume it's a mom, but it might be a dad. What about a colonoscopy, though the GP is reluctant to do this? And this family has been following the tests that were set out by the guidelines, the 2001 guidelines that I just mentioned. So what about constipation? Next slide, please. Part of the challenge in answering this is that there are many different causes of constipation and abdominal pain. It's more like headache. There are many causes of headache. So without knowing a lot of the details, it's hard to respond in either case. But assuming the constipation is what we call functional constipation, that's the most common cause of constipation in childhood, there are definitely strategies that can be employed: adequate hydration, food with enough fiber, good bowel habits, and I don't want to minimize that. I mean, having a regular time and the opportunity to use the bathroom. I think this can be hard because I think some adults have a very either irregular schedule or fragmented schedule, but trying to identify a consistent time to use the bathroom is important. And then there are over-the-counter medications, Miralax fibers, but there are now also new prescription medications that can be used to manage constipation, and those fall under the province of a gastroenterologist. But there's enough tools to bring to bear that most adults with Williams syndrome we should be able to prevent chronic constipation. In terms of doing a colonoscopy in a 25-year-old, as was asked, I wouldn't leap to that first. I would want to make sure that a GI specialist has been involved and there's been a thorough workup before going to a colonoscopy. A lot of families ask, can an adult with Williams syndrome tolerate a colonoscopy? I would say that it's been successful in probably 80% of those who tried it. The clean out is not a joy, as any of you who've had a colonoscopy know, but adults are able to do it, and the procedure itself probably needs to be blessed by the cardiologist and probably needs to be done in a hospital unless the cardiologist says it's okay to be done elsewhere. But we have not had significant difficulties with adults unable to tolerate a colonoscopy. Next slide, please. So, Terry, can you give me the next slide?
I put it up. What is diverticulitis and why does it seem to be more common in adults with Williams syndrome?
Oh, there it comes. Okay. So what about diverticulitis? Okay. Yeah, sorry. There was just a lag. Next slide, please. So let's define what's a diverticula first. So diverticulitis is inflammation of a diverticula, just like appendicitis is inflammation of your appendix. So here is a cartoon of the colon, and a diverticula is an outpouching or pocket in the GI tract. Normally, these develop over time. Probably everybody listening in on this webinar has diverticula. Next slide, please. So in the general population, 5 to 10% before age 50 have them, and then they go up in frequency with age. Sorry. So it's like a weakness or an outpouching. The diverticula develop earlier in individuals with Williams syndrome. We're not entirely sure why. It may very well be due to a combination of the elastin deficiency and possibly strain on the bowel wall from chronic constipation. I mean, those are hypotheses, but they seem like reasonable hypotheses. So here's the colon, and let's see, there's the appendix, ascending, transverse, descending colon, and then that's the rectum. The common location for these diverticuli to develop. And then if I take a cross section here and then look inside the colon, this is a cross section, that's what one of the diverticuli look like. The weakness, or as you say, an outpouching. By and large, these diverticuli do not cause problems in and of themselves. Again, next slide, it's going to bring in a screenshot. Yep. So here's another picture. Here are the diverticuli. It's a cross section. Here's a diverticuli that's just sitting there. here's a diverticuli that has gotten impacted, inflamed, infected, and then ruptured. So now this is a diverticulitis because the content of the bowel, which includes lots of bacteria that's supposed to stay inside the bowel, is now leaking out into the abdomen. Next slide, please. So, unsurprisingly, okay.
I'm going to get right.
That's great. Again, like appendicitis, we have an inflammation and an infection and possibly leakage of bowel contents into the abdominal cavity, so that symptoms such as those listed here are to be expected. Actually, now I'm going to confuse you. Can you go back?
Here?
I just wanted to see a picture of, I'm sorry, there must be a lag. So the management of diverticulitis, I'm not seeing a picture of the bowel, but that's okay.
You're not?
And no, I'm still on the typical diverticulitis symptoms. I think there's an internet lag. My apologies.
Yeah, there's
here we go. So this can, in some cases, be managed medically, antibiotics, and I've had several adults who've had more than one bout of diverticulitis that has been managed medically. Sometimes, however, depending on the extent of involvement, how many pockets there are and how many have gotten inflamed or infected, and if there's been rupture, sometimes surgery to remove the diseased area of the bowel is needed. Prevention, whether preventing chronic constipation will minimize the likelihood of diverticulitis. It's possible, so we think it's a reasonable strategy, but as of right now, there is no other preventative to recommend. So next slide.
Back to the symptoms, or do you hear?
Yeah, keep after diverticulitis, and then whatever the next slide is.
So the new question.
Yes, which I can't see. So can you read it?
I'll read it to you. Yeah. D has been struggling with a severe cough for 2 years. We are unsuccessful in finding the cause. We are wondering if considering his condition from a Williams syndrome perspective might shed some light on the problem. He will be 54 in May.
Okay. So again, I'm unfortunately looking at colon still. That if you go to the next slide.
Okay.
Yep. One more. The
response.
I'm seeing the severe cough. The question.
I have the responses.
Oh, there it is. So many different causes of cough, and I've listed a few examples here, most of which you're probably familiar with, but not necessarily all. Allergies, chronic sinus problems, reflux, so lung disease, asthma, bronchitis, which can happen to anybody, and emphysema, which can also happen to anybody, but is probably more common in Williams syndrome adults, again, because of the elastin problem. Certain cardiac findings can be associated with chronic cough. Certain medications, a side effect is chronic cough. And then what gets called a habit cough or a tic can also be one of the possibilities. So I'm unsure of what has transpired in the last 6 months since this family wrote in with this question, but this would certainly merit further investigation, and the appropriate specialists are listed here. Next slide, please.
Wait a minute. What do we know about menopause and Williams syndrome?
So when I got this question and both started to think about it and read about it, there's really a simple answer, and it's basically nothing. You can go to the next slide. I was very disappointed. We know nothing about menopause and Williams syndrome. So I was being polite when I wrote my answer and said next to nothing. There is no scientific data on the average onset of menopause in women with Williams syndrome. Is it the same or different than the general population? I mean, we know that puberty starts a little earlier in Williams syndrome. Does it follow that menopause is going to start a little earlier? We just don't know. There are no data. There are no scientific data on the range of symptoms. Are they the same or different than the general population? So I decided to read up a little bit more on what are the menopause symptoms in the general population, and can it help us at all understand what might be going on in Williams syndrome women going through menopause? So the next slide, I've listed some of menopausal symptoms in the general population. Not all of them, but I've listed the ones that perhaps could be more impactful for women with Williams syndrome. So the common symptom, the most common in, I suspect, all studies is hot flashes, so fluctuations due to fluctuations in estrogen. Another very common symptom is sleep disruption. And hot flashes could be contributing to sleep disruption, but sleep disruption seems to be more than just hot flashes. Depressed mood and anxiety. So in the general population, if you have a history of depression, you are more likely to experience depression again in menopause. In terms of anxiety, the risk of anxiety seems to go up in menopausal women in the general population, whether or not they've ever had a history of an anxiety disorder. So, okay, and this is during the perimenopausal years. So this is a few year period between the onset of menopause and once you're finally through it. So it's important that once you're sort of through menopause, these symptoms do not persist forever. So weight gain, particularly in the middle, sort of the abdominal region, or what we call the apple distribution, is common, these features here are perimenopausal. These two features, weight gain and decline in bone health and lean muscle mass, those start at menopause and those continue. And then another common complaint, reduced performance in the workplace in the general population, and whether that is due to worsening memory and a worsening concentration. So when I tried to look, are these the kinds of symptoms that happen in menopause in women with intellectual disability? That's on the next slide. I mean, there is like one study. On average, in women with intellectual disability, menopause occurs slightly earlier than in the general population, but this is confounded by the fact that often people are including women with Down syndrome, where their hormonal profile is very different, and they definitely go through menopause earlier than the general population. This single study on menopause symptoms in women with intellectual disability, this was a population of adults with Down syndrome and non-Down syndrome. The most common symptoms were hot flashes, similar to the general population, weight gain, similar to the general population, poorer sleep, similar to the general population, and then mood swings and feeling of sadness, but according to the authors, they were unable to separate out whether these mood swings and feelings of sadness had to do with menopause or were due to the other experiences these women were having in their daily lives. So my takeaway about menopause is, again, we know so very little. This is definitely something that should be studied in women with Williams syndrome. And in terms of treating it, I think, it's not a matter of, well, just tough it out. In a couple of years, your hot flashes will go away. I think whether hormonal treatment or sometimes the SSRIs can help. I think treatment ought to be sought, but whether it in and of itself explains some of the emotional lability that is occurring at around this time, I think is an open question, but certainly one that merits further study. Next slide. I have a minute to do 30 slides. Excellent. So this question is about a young adult who's had a heart murmur, and basically how often should she be checked by a cardiologist because she's had a heart murmur but no significant heart problems have ever been diagnosed, and could she develop heart problems later on? Next slide, please. So our cardiologists that we work with recommend cardiology visits every 3 to 5 years for adults with Williams syndrome, even those without significant heart disease. And the reason for this is that some things can change over time. This includes, but is not limited to developing high blood pressure, developing floppy or leaky valves, and the EKG changes, including effects on QTc interval due to medication. Ideally, if your adult family member with Williams syndrome can be seen by a cardiologist who specializes in adult congenital heart disease, and that would be ideal. Not that the general cardiologist can't manage Williams syndrome, but they are in all likelihood not as knowledgeable about someone who specializes and has extra training in what we refer to as adult congenital heart problems. So Terry, it's up to you whether we continue. I am.
Well, I think, in light of the fact that we have, we've done this twice, and we're trying to go, to get some more questions answered. If you're willing to go, you want to go 15 more minutes, or do you want to cut it? It's totally up to you, Barbara. And then, sure, folks can drift off if they have things to do, for sure.
Yep, I will do, let's aim for 15 more minutes, and I understand people need to go.
Right.
So next question about, and again, and a lot of these questions I don't know a lot of the answers to, so they will be quick, some of them. It's normal to have circulation problems, and can this be linked to SBAS? Next slide, please. So I'm not sure what circulation problems means, but if you're referring to the hands and feet getting cold and blue and blotchy, this is generally not due to SBAS. But again, you must discuss this with your cardiologist who knows your child's vascular status. But we see a lot of purple hands and feet, and it's not SBAS. So this question has to do with a young man of 36, and his GP is recommending Prolia injections for osteoporosis on DEXA scan, and then osteopenia, so milder bone thinning in femur and spine. What are my recommendations? And he also has celiac disease, so the doctor's hesitant to give oral bisphosphonate, so that would be an oral bone strengthening medication. Next slide, please. So I do have an update on this since the last time we looked at this. So I'm unfortunately not seeing my response, but I'll say, and I have not, well, I probably have it memorized. As we reviewed on that long table of potential medical problems, we see decreased bone density, so both osteopenia and osteoporosis, in males and females with Williams syndrome. And that is quite distinct. In the general population, it's far more likely that women are going to have bone thinning than men. But in Williams syndrome, we see both. Okay. So initial therapy is to make sure that the recommended daily intake for calcium and vitamin D are being met, that the individual is engaging in weight-bearing exercises, so walking, going upstairs, making sure that the testosterone level and the vitamin D level are not low. Now, an injection like Prolia, in theory, could be preferable over a pill, particularly if someone has reflux. But there's been a lot of recent attention that that Prolia works. Prolia increases your bone density. But once you stop Prolia, you lose a lot of the bone density that you gained, and there's an increased risk of vertebral fractures. So I'm not if Prolia is the right medication, for anybody at this point. And for an adult with Williams syndrome, this needs to get discussed with the doctor. I didn't write it here, but to me, celiac disease is not a contraindication. Celiac disease is not a reason not to take an oral bone strengthening pill. A bigger contraindication is reflux or the inability to sit upright for 30 minutes after taking a bone strengthening pill. Next slide, please. So now we're getting to several orthopedic questions, and my knowledge on the orthopedic aspect of issues is thin, as you will see. So I apologize. What helps with joint discomfort? Next slide. I think I wrote that this is why is there joint discomfort? What joints are involved? What treatments have been tried? What workup has been done? Is there a concern in the back of the family's mind about arthritis? I see occasional patients with arthritis, but I don't think it's an increased frequency over the general population. So I apologize. I don't feel like I have any great insights here. So next slide, please. And I'm still stuck on what helps with joint discomfort. So can you read this?
Okay, so the question is, are you seeing foot problems related to a fused joint and or arthritis? It may just arise in those WS individuals on their feet for several hours a day at a job.
Right. So I think this one was about talonavicular fusion.
Yes. Yeah.
So on the next slide, which I also can't see, I have
got a nice picture
the bones of the foot, and there's a line pointing to the talonavicular joint. So if if there are certain foot problems, the hindfoot laxity, certain type of flat footness, one treatment option is fusing that joint. I have encountered, the thousands of people I've provided care for, admittedly, some of them young children. I've heard of talonavicular fusion in 2 or 3. So I don't know if there's something about this joint that's more frequently abnormal in Williams syndrome. I also wasn't, happy to brainstorm about next steps, no pun intended. Wasn't sure if the foot problems were due to the fusion or mom is concerned about arthritis. I do hear about foot pain. I'm still back. I do hear about foot pain in adults with Williams syndrome who are on their feet a lot. And again, it's hard to know. A lot of adults don't do a really good job of wearing shoes with lots of support. They do what I refer to as the sneaker loafer phenomenon. They just sort of slide their foot in their sneakers without really tying, whether orthotics would help. The foot problems that I hear about are more often in adults who are heavy. So again, I'm not sure I'm having a lot of insights and intelligent responses here, but I'm certainly happy to brainstorm more with this family. And the next orthopedic question with femoral anteversion. Again, outside my wheelhouse, on the next slide, there's a picture of what it is. It is not something I see commonly in Williams syndrome. I do see decreased external rotation at the hips, the ability to externally rotate. But if there's a frequency of femoral anteversion, I apologize, I am not appreciating it. And I would encourage this family to get a second opinion from a knowledgeable orthopedist. Next slide. So calcitonin is elevated. What does that mean? Another perplexing question, the next slide. Without considerably more information, and again, I'm happy to receive it, but we don't routinely check calcitonin. Why was it checked? How high? There's certain medications that might increase it. Abnormal kidney function can increase calcitonin. There's certain thyroid gland abnormalities that could increase calcitonin, and I would hope that an endocrinologist has been involved. Next slide. So these both have to do with blood disorders. Is there a predisposition to blood disorders? And the second question was a young man who has decreased white blood cell count, abnormally low. He also has a high calcitonin. So again, I'm not sure what that means. Next slide, please. So in terms of blood disorders, we just published a paper with this title, mild macrocytosis. So we looked at 100 of blood counts, and what's mild macrocytosis is a slightly larger than typical red blood cell. And on the CBC, the printout is a mildly elevated MCV. So when this is an isolated problem, we think it's just one of these things we see in Williams syndrome, and that is unlikely to indicate an underlying medical problem. As part of this, we collected lots of white blood cell counts too. We didn't systematically analyze them like we did the red blood cell counts and the MCV, but most of the white blood cell counts were normal, though some were low. So again, how much variability there is in white blood cell counts is a topic for future research. In terms of blood cancers, 10 patients with Williams syndrome have been reported with this type of lymphoma. And whether this is more common than the general population is unclear. By and large, Williams syndrome does not seem to be a cancer predisposition disorder. There are other genetic disorders that are. Williams syndrome doesn't protect you from getting what anybody else could get, especially something running in your family. But based on our current knowledge, Williams syndrome does not seem to increase the risk for either blood cancers or other types of cancers. Next slide. So this is several questions here: an abdominal aneurysm, kidney problems following a CT scan and MRI, and a rectal fissure. Again, next slide. For the combination of an abdominal aneurysm in a person with Williams syndrome is unusual, so I would defer to my cardiology colleague. And in terms of these other issues, hopefully they've resolved. If not, kidney and the rectal specialist would need to get consulted. Next slide, please. Okay.
We are at 9:15, Barbara, so I don't know what, I leave it up to you.
Well, there's one more slide. There's one more that I want to talk about. If you,
okay.
I feel badly that we can't be zooming through them. Next slide, please. Next slide, please. So if you can go back, this is the slide that I'd like to spend. What can we do to prepare for support services, in-home care, assisted living? And how can we prepare and plan for health concerns or unexpected medical events, especially when self-care is no longer an option? So next slide, please. So planning in advance is the key. I frequently am in clinic and see 80-year-old parents bringing in their 50 or 55-year-old family member with Williams syndrome for an appointment. And when we discuss, so, you know, what are you thinking of down the road? Well, he's going to live with me forever. And to which I have to say, well, that's likely not the case. And in fact, just this week, I was reached out to by a family member who said basically her 100-year-old grandmother was no longer in a position to provide care for her mid-70-year-old family member with Williams syndrome. What were the options? So in all likelihood, I mean, the harsh reality is the greatest likelihood is your child with Williams syndrome will outlive you. It's not for certain, but in all likelihood that is the case. And I think I appreciate how hard it must be to make these difficult choices about planning for your child, your adult child's future when you are no longer part of it. But my sense is I would much prefer you to be making decisions than the state, who does not know your child and probably does not have your child's best interest. at heart. So planning for who every adult with Williams syndrome needs a go-to person. And as I like to say, they have several people on speed dial. It's usually mom or dad, but then there are other people going down the list. But when mom and dad aren't available, aren't able to do this anymore, plans need to be put in place to help with the transition to the next stage of their life, which is after you are active players in it. And because I've increasingly seen this phenomenon, I brainstormed with Terry. Terry had certainly been hearing about it from different sources. We are planning an upcoming session at the WSA Family Convention to try and help families identify options, maybe identify checklists of things that need to be done or that are going to make that transition easier. And Terry, do you have anything you want to add at this point? Because I know you and I have talked about this a great deal.
Yeah, no, I think the main thing, just like you said, is that definitely plans have to be made. The situations that we've heard of where a parent suddenly passes and the siblings, or maybe there's not siblings, but even if there were, that there was nothing in place for what's next, and that time of just confusion really is a adverse effect on the individual with Williams syndrome. And anxieties go through the roof, and behaviors change dramatically. And it's really, everybody says, but he just needs to stay at home, or he's not comfortable going someplace else. It's going to be much more comfortable for him to go someplace else when he can still come back to visit periodically than when suddenly there's nothing else, is what I'm seeing from folks. And so I think you just can't state it enough that we have to make plans,
right,
and we have to bring in folks who can help us do that.
Right, and again, and the range of plans that I have heard, go from like amazing, meticulous. I have some amazing families who have thought this through, and I'm learning from them. But then there are other families. Well, he's going to live in the house he's comfortable with, and I'm going to have a neighbor come check on him a couple times a week. And these are, to me, disasters waiting to happen. And for all that it's incredibly hard on everybody, again, it will be much harder on the person with Williams syndrome who has lost their main support system throughout their entire lives, without new supports having been put in place. So,
the other thing, especially we hear, the siblings live, on the other side of the country. And so they're just planning on, they're going to uproot their sister or brother and bring them again away from their community and their support system to suddenly, live on the other side of the country. And without preparation, that's just as hard. Even though they still have a family member, it's just as disruptive.
Right. And in addition to, the leaving their community, their home, their entire medical team needs to get reassembled. And so not that it can't be done, but that it needs to be planned. There needs to be a transition uh, that is gradual, as opposed to having kind of the rug pulled out from under you. So not an easy topic at all. Not an easy topic to close on, but it's one that I think as a community, now that people are living longer. I mean, that's the good news. People are living longer with more independence, but still, every adult that I see needs supports to varying degrees, and we need to help WSA, the medical providers, and the families need to work together to articulate, identify, list options, and then it's up to the family to choose the option that works best for them. Well, thank you all for your patience, and don't hesitate to write out to email me to write if there are questions.
Right. I also wanted to apologize, for the lag a little bit in both slides. Barbara being able to see her slides, there was a lag there. There were also, I kept getting notices of audio issues, so I'm not sure how good the recording is going to be for this webinar. But even if it comes in and out, we'll edit it and put as much of it as we can up online for everyone. So again, thanks so much for coming. You have made history. This has been the largest attended webinar we've ever had. So you can put yourself down in the record books for that. And again, thanks so much. I hope that we will be able to travel to Phoenix this summer, and we'll see many of you there. Thanks, everyone. Good night.
Good night.